Good morning, everyone. First of all, I would like to thank Dr. Pandurangi for this invitation. And I'm very happy and excited to be a part of the first National Physiologic Pacing Symposium. It is truly an honor to come back to the home country and talk about our experience on conduction system pacing. I have no disclosures. So a little bit about myself. I was born and brought up in Hyderabad, did my med school at Kamineni Institute of Medical Sciences, graduated in 2007. Went to residency, finished my 3 years of internal medicine residency at UConn, did 3 years of cardiology fellowship at Albany Medical Center, and then I was fortunate enough to join EP fellowship at Virginia Commonwealth University under Dr. Kenneth L. Morgan. And it was during this time I came across this guy who's the most hardworking co-fellow, and that's none other than Parikshit Sharma. He was my senior EP fellow during the training. And after the fellowship, I stayed back as faculty at VCU, and this is my third year as faculty there. So I'm going to talk about the anatomy and physiology of conduction system today. So back in the 19th century, there was a huge debate as to whether the cardiac impulse propagation happens either via the myocytes or the nerves. It was not until 1906 when Tawara, a Japanese pathologist, for the first time described the existence of specialized myocytes which make up the cardiac conduction system axis. So this is the original publication figure from 1906, and you can see the specialized conduction system axis in orange. You can see the AV node continues as the His bundle, which you can divide it into three parts, like non-penetrating portion, the penetrating portion, and the branching portion into right bundle and the left bundles. This is a depiction from McAlpine's Atlas. This is a very simplified version of the cardiac conduction system. This is looking from the RA view. This is the right atrium, right ventricle, and the orange is your conduction system. You can see the AV node continues as the His bundle, penetrates the membranous septum, gets to the left side, and then you can see the right bundle coming down, branching out into Purkinje fibers, which supply the pap muscles. When you look from the left side, this membranous septum is closely related to the non-coronary cusp and the right coronary cusp. And you can see the His coming out of the lower border of the membranous septum and then divides into the right bundle and the left bundle. The left bundle again further divides into left anterofascicle and the left posterior fascicle. Again, most textbooks show this line depictions, which sometimes can underestimate the complexity of the cardiac conduction system. Let's look at some anatomical landmarks. So this is, these are the images from Sabine Ernst and Yen Ho anatomy textbook. So this is, again, the right atrium, the right ventricle, the septal leaflet of the tricuspid valve. One of the important landmarks we have here is the triangle of Koch. You can see the septal leaflet of the tricuspid valve, the tendon of Tadaro, and the base is formed by the CS os. One of the components of the triangle of Koch is the compact AV node. You can see here, which as it continues distally, it becomes the bundle of His, and then it penetrates the membranous septum. This is looking from the top. You can see the pulmonary artery, the aorta, and the mitral valve and the tricuspid valve. So this is the interatrial septum between the right and the left atrium, which can further be divided into anteroseptal area, where you have the His, the mid-septal area, where you have the compact AV node, and the posterior septal area, which is actually the pyramidal space. Notice the relationship on the right and the left side. On the right side, you have the septal leaflets and the anterior leaflet of the tricuspid valve, whereas the left side, it's closely related to the right cusp and the non-cusp. And again, this is from the left side. You can see the aorta. This is like your pasternal long axis view. So the right cusp, non-cusp, and this is the membranous septum, where the His bundle comes onto the left side and divides into bundle branches. These are a few more images looking closely at the membranous septum. This is the right side view, this is the left side view. And you can see this blue dotted area is the membranous septum on the right side, membranous septum on the left side, and the red dots are the course of the cardiac conduction system. In the lower panel, in here is the long axis 4-chamber cut view. You can see the right atrium, left atrium separated by the interatrial septum. You can see the RV, LV separated by the interventricular septum. The interventricular septum can be divided again into membranous septum, which is marked by the arrow, and the muscular septum. This area is zoomed in here, and you can closely again see the membranous septum here marked in blue dots. Notice the relationship between the membranous septum and this black dotted area in figures B and D. The black dotted area is the central fibrinous trigone. So it's very important to understand the anatomy because it's going to help us during conduction system pacing. So it's also crucial to understand the histology of the structure surrounding the cardiac conduction system. So here the histology is shown at various levels. This is, you can see the membranous septum, and this is the muscular septum. Here you can see the membranous septum is again divided into two parts by the tricuspid valve hinge point. Above the tricuspid valve, you have the atrioventricular membranous septum. Below the tricuspid valve, you have the interventricular membranous septum. So I don't know if you can make it out, but there's an asterisk here that points to the area where the His bundle penetrates from the right side to the left side. So the His bundle typically penetrates, in most of the cases, at the lower border of the membranous septum. Again, there might be some variations, but majority of the cases, it penetrates the lower portion of the membranous septum. As you go further down, you can see these are stained with Mason trichome. The green is the fibrous tissue, and the red is the muscle. And you can see the asterisk, which is the His bundle. Notice its relation to the fibrous tissue. Okay. So what does it mean? So again, if you look closely at the penetrating bundle of His and take a histology at this level, you will see the red area is the His bundle, and it's completely encased by the fibrous tissue. This is very important to know because since it's encased by the fibrous tissue, which is electrically non-conducting, that's probably one of the reasons why you have higher capture thresholds with the His bundle pacing, as opposed to left bundle branch area pacing, which is surrounded by dense septal myocardium and not fibrous tissue. This is the left bundle branch in the human heart. This is, again, a picture from 1906 Tavares publication. And you can see this is the left ventricle. These are the aortic cusps, membranous septum, and then the left bundle comes down, divides into left anterior fascicle, left septal fascicle, and the left posterior fascicle. And you can see these fascicles then arborize into several small Purkinje fibers, which go on to supply the pap muscles and the LV subendocardium. Same network can also be seen in bovine hearts. Again, here is a beautiful image of the left ventricle showing the left bundle dividing into left anterior fascicle, which is traversing towards the left, towards the anterior pap muscle, left posterior fascicle traversing towards the posterior papillary muscle. Notice the rich intercommunications between the fascicles provided by the Purkinje fibers. And you can see the dense network on staining. This was a publication from Nature. It's actually very beautiful in that in this publication, they were able to map the entire cardiac conduction system using high-resolution, contrast-enhanced micro-CT imaging. The spatial resolution was incredible. They were able to look at single cardiac myocyte. By doing that, they were able to delineate the entire cardiac conduction system. So these are some of the images from that publication. On the left side, you can see the histological representatives. On the right side, you can see this is a micro-CT imaging, and you can see, based on the contrast uptake by different structures, the conduction system was able to be identified. So this is the compact AV node marked in red here. And as you come down, you can see the penetrating bundle here. And as you go down, you can see the right bundle coming along the ventricular septum. And these are the short axis views where they were able to delineate the left anterior fascicle, posterior fascicle, and septal fascicles. They also did some 3D anatomic reconstructions. So this is the His-Purkinje network looking from the right side. So this is your right atrium, tricuspid valve, right ventricle. Again, looking from the right side. You can see the green marked area is the AV conduction axis. So this is your AV node. As it continues distally, it becomes a His bundle, penetrates the membranous septum, comes onto the left side, which is below the right cusp and the non-coronary cusp, and then it divides into right bundle and the left bundle. You can see the right bundle is marked in red. It's thin ribbon-like structure, comes down and fans out into Purkinje fibers. And then the left bundle, you can see it better from the left side here. So this is looking from the left side. Again, you can see the right bundle in red. The left bundle is a thick band-like structure, which again divides into left anterior fascicle, septal fascicle, and the posterior fascicle. Note how the left posterior fascicle is thick and band-like structure compared to the anterior and septal fascicles, which are thinner. These are again some more images from their publication. You can see the sinus node in turquoise color, and then the green is the AV node. This is looking from AP view. This is the right bundle and its branches, and the left bundle. This is with myocardium overlaid on top of the conduction system. And this is one of their examples of cardiac isochronal map during impulse from sinus node. So when we talk about conduction system pacing, when we talk about His bundle pacing, we are targeting this small, precise target zone. Okay. And when we talk about left bundle branch area pacing, we have a wider landing zone. You can either get the lead at the basal septum close to the left bundle, or you can sometimes go down as low as mid-septal area. Again, it's very important to understand, again, the anatomy and the histology, I think overall favors left bundle branch area pacing over His bundle pacing. If you think about it, the His bundle, it's a very narrow, precise area, requires higher precision, and now you're screwing in the lead, and if you think about the histology, it's surrounded by the fibrous tissue, whereas the left bundle branch, it's a wider landing zone and has a dense septal myocardium. So that was the anatomy. We'll also talk a little bit about the physiology of conduction system. So when we talk about the side of bundle branch block, where exactly is it? So if you take a patient with the right bundle branch block, what is the most likely side of block? Is it at the AV node, is it at the His, or is it in the right bundle branch? Okay. Is this one? At least late until my cardiology fellowship, at least I used to think that when patients have right bundle branch block, the block is in the bundle branches. But now we know that the block is actually, majority of the times, it's in the intra-His portion. So this is the concept of the longitudinal dissociation, where the fibers which are predestined to become right bundle are blocked in the His area. So if you can get your pacing lead distal to the side of block, you will be able to recruit the right bundle or the left bundle. Again, if you take a patient with left bundle branch block, where is the most likely side of block? Is it, again, at the level of His? Is it at the left bundle branch, or is it distally? This was a publication from Rottung where they looked at all patients with left bundle branch block. They were able to map the left side of the septum using a multi-electrode catheter. And what they found was that in about 46% of the patients, the block was located in the intra-Hisian region. And about 20% of the patients had block in the left bundle branch. And in about 35% of the patients, there was intact Purkinje activation. So these are the patients who have baseline left bundle branch block at baseline, but about 35% had intact Purkinje activation. That tells you that in those patients who have intact Purkinje activation, even if you put a His bundle lead or a left bundle branch pacing lead, it's not likely going to correct the widening of the QRS. So those are the cases still which won't be able to be corrected with his bundle or left bundle branch area pacing. And when we talk about conduction block, is it real block or is it just a delay? So here I'll show some examples. So this was a patient with right bundle branch block, and you can see in the V1 rhythm strip. So this was the baseline rhythm. Every time after a PVC, following a pause, there was a narrow QRS beat followed by right bundle branch block. So this tells you that the right bundle branch block at baseline was functional. So how does this happen? So if you see here, the patient has a right bundle branch block beat followed by a PVC. After a PVC, there is a long pause, which allows the right bundle to recover from its refractoriness, and you get a narrow complex beat. Following this, the sinus impulse comes on time and finds the right bundle refractory, and you get a right bundle branch block. So this is your classic long shot leading to Ashman phenomena. So the refractory periods of the bundles depends on the previous RR intervals. So for this narrow complex beat, the refractoriness of the right bundle depends on the previous RR, which is long. So the right bundle refractory period is long. So the sinus impulse finds right bundle to be refractory, and you get right bundle branch block. So how do you explain the perpetuation of right bundle branch block? That can be explained because when you have right bundle branch block, you have the impulse coming down the left bundle, goes transeptal, penetrates retrogradely into the right bundle. So when the next sinus impulse comes in, it finds the right bundle refractory, and the right bundle perpetuates. So the long shot leads to right bundle branch block, and the concealed repetitive penetration leads to perpetuation of the right bundle branch block. And you can see the short long results in resolution of the right bundle branch block. It's like reverse Ashman phenomenon. This was another interesting case we had. This patient actually was in his 70s, presented to us with recurrent syncopal episodes, and he had baseline left bundle branch block. When we brought him to the lab to do a EP study, you can see he had a premature ventricular beat, the morphology of which was almost similar to his baseline left bundle, and following that, there was a long pause. Basically, you had a peel back of refractoriness and normal QRS complexes. So this was repetitively demonstrated, and you can see here with the His bundle electrograms, you can see this was a His extrasystole leading to peel back of refractoriness of the left bundle and normal QRS complexes. It can get even fascinating. Here you can see an example where patient had sinus rhythm with atrial bigeminy. Every time with the PAC, you can see there's a right bundle branch block, sinus beat with narrow QRS, PAC with left bundle branch block. So there was alternating right and left bundle branch block. So the way you explain this is it's due to alternating long short phenomena in the bundle branches. And this is again a functional block. This is a ladder diagram for that. So why do conduction system pacing? So we all know that patients who have get our chronic RV apical pacing over time, 15 to 20% of the patients can develop pacing-induced cardiomyopathy. This is due to both interventricular and intraventricular dysynchrony created by the wide QRS complex. Once this was realized, people started implanting high up in the RVOT or in the RV septal area, but still the outcomes were not different. Even when we do traditional biventricular pacing, you're pacing at two non-physiologic sites, that is the RV apex and the CS. That probably explains the ceiling effect of biv pacing in patients who require cardiac resynchronization therapy. Whereas if you look at the His bundle pacing, you're pacing at the His, it comes down to the bundle branches and activates the ventricles, providing the ideal modality to create electrical and mechanical synchrony. So when we put His bundle leads, where exactly are the leads? Are they above the tricuspid valve or below the tricuspid valve? This was a publication from CIRC. This patient actually ended up dying from a non-cardiac cause, underwent autopsy, and you can see the His bundle lead is above the tricuspid valve. And this is transillumination of the membranous septum from the left side. You can see again the His bundle implanted at the membranous septum above the tricuspid valve. These were the histology specimens, again proving that the His bundle location was above the tricuspid valve. Again, it can be demonstrated on the transthoracic echo, in the apical four-chamber view, in the CT scans. Majority of the cases, it's above the tricuspid valve. This was one of the cases from our lab. This patient had a His bundle lead. After a few years, he had severe right-sided heart failure due to severe TR. He was taken to the lab for tricuspid valve replacement. It was a mini thoracoscopic approach, and you can see there was marked tricuspid annular dilatation. You can see the septal leaflet, the posterior leaflet, and the anterior leaflet of the tricuspid valve, and you can see the His bundle lead above the tricuspid valve, again telling you that that's not the cause of his tricuspid regurgitation. Finally, left bundle branch pacing leads. This was from the canine models, recently published in JCE, and you can see here, looking from the right side, this is the His bundle lead, and this is the left bundle branch area pacing lead. When they looked on the left side, you can see the arrow points where the helix of the left bundle pacing lead is, and when they did the Lugol's iodine staining, you can see the left bundle branch and all its branches, and you see how close the helix is to the bundle branches. I'll just end this talk with this video from, again, the Nature paper. Depicting the human cardiac conduction system. It is slow. Sorry. I think we can skip it. That's fine. I think I'm done. Thank you.